Starting. All attendees are in listen-only mode.
Thank you for attending the STN monthly webinar. This session is being recorded so that it can be offered as on-demand CE for our members. Your lines are muted, but if you have any questions, please type them into the question queue and we will address them at the end if we have time. STN is an accredited provider of continuing nursing education. To claim CE for this session, you must attend the entire session and complete the online evaluation of the presentation. If you are attending this session live, you will receive an email about 1 hour after the event with directions to complete the evaluation. Certificates will be emailed approximately 7 to 14 days after today's event. If you are viewing the session as on-demand CE, you will be able to download your certificate after completing the quiz and evaluation. We hope that you gain great value from our educational session. Today's speaker is Heidi Almodovar. Heidi's been a trauma nurse practitioner at 2 different level 1 pediatric trauma centers. She has 22 years of pediatric nursing experience, primarily focused on pediatric critical care and pediatric emergency nursing. She has worked as a staff nurse, a flight nurse, clinical coordinator, and a clinical nurse specialist, and for the past 13 years as a pediatric trauma nurse practitioner. In her most recent role at Boston Children's Hospital, Heidi provided continuity of care for pediatric trauma patients throughout their hospitalization and in follow-up in trauma clinic. She served as a clinical expert and educational consultant to colleagues throughout the institution and in the greater Boston community. Heidi actively contributed to PI and QI initiatives, program development, and program evaluation. She has also served as preceptor to acute care PNP students. Heidi is passionate about caring for the pediatric traumatically injured child and their family. She is committed to educating all members of the healthcare team as well as patients and families. Please welcome Heidi.
Good morning or good afternoon, wherever you might be. I'm talking to you from sunny St. Petersburg, Florida today, and I'd like to thank the committee for inviting me to speak and thank you all for joining me over your lunch hour. I most recently practiced at Boston Children's Hospital, but have been in Florida for several months now. So when I say we, I'll be talking about Boston Children's Hospital since I still feel like I'm a team member there and miss my colleagues greatly. So I have no disclosures to provide today. This is from STN about the certificate that you can get at the end of the session if you fill out the forms for 1 contact hour. And we will start with this saying from Mahatma Gandhi, which I love. The best way to find yourself is to lose yourself in the service of others. And that's how I feel about our profession. And as Brian just mentioned, I've been a nurse for over 20 years now, and it's been one of the greatest privileges of my life to work with trauma patients and their families, as well as with an extraordinary group of coworkers, most of whom I call great friends. And I hope I can relay some of the passion that I have for what I do today to you. So our objectives today are threefold. First, to have a better understanding of how our patients and families define excellence. Next, to talk about some of the foundations of crisis resource management principles and how they relate to excellence in patient care. And then begin to appreciate, maybe some of you for the first time, this term holding space and recognize how it greatly impacts our patients' and families' experience. So first, I just want you to stop for a minute and think about why you went into healthcare in the first place. And does your professional experience today still meet your original expectations, at least most of the time? And do you feel passionate and fulfilled and revitalized after most days at work? And then I want you to think quickly about your best day at work ever, and I'll share mine with you here in a moment through a case scenario. But I bet that you were excellent in some way, and that's what made you feel so good about it. But I also bet that your patient felt your excellence and positive energy too. And that's what our patients and families deserve from us every single day. But how do we sustain that level of satisfaction and excellence? I believe it starts by defining what excellence in practice means to you. So when we talk about excellence in healthcare, much of the bubbles you see here is what comes to mind. But if you look at most hospitals' patient bill of rights, that's what these terms reflect. So this should be our patients and families' baseline expectations. So to me, this is not what defines excellence. And your personal definition of excellence, which is why I would like you to write it down at some point this week, particularly in your clinical practice, will lead to different priorities and goals in your practice that will then be reflected in your practice. So it's important for you to define it for yourself and then act it out with intention. But what happens when we are consistently excellent? Well, it becomes the norm, and our patients and families come to expect that of us, so it's no longer excellent, it's an expectation. So how do we up our game day after day? And I hope I provide you with some examples of how to do that today. So here's the dress that is seen around the world, and as many times as I look at it, I swear to God it's only gold and white, but people tell me that if you squint and look at it in a little bit of different light, that it can be black and gold. The reason I bring this up is I love this saying by Heather Plett, who is a teacher, writer, and coach from Canada, who writes quite a bit on this idea of holding space, which we'll address later. But she says one of the greatest opportunities in the world is not to convince others to see things your way or to appreciate what you believe excellence is, but to try and see things in a new way. So knowing how you define excellence is a great place to start. But what really matters is how our patients and families define excellence, since they're the population that we serve. And we may be surprised to find out that our definition may not be in alignment with our patients and families. So after more than 20 years of nursing practice, I decided to ask our patients and families. So we sent patient satisfaction surveys with specific questions to over 600 patients and families, and two main themes started to emerge. Number one, we'll talk about first, is that families sensed a calm, controlled environment where there was clear direction and that they truly felt that that resulted in superb care. Some of the quotes, comments that they wrote in were what was chaos in the outside hospital emergency room turned into control in your emergency department. Everyone was so focused and had their specific job to do. It was clear who was in charge. You could hear a pin drop. It was a well-oiled machine. So clearly they sensed and felt this calm, controlled environment. And let me give you an example through a case scenario and why I think we do such a good job of relaying that to our patients and families. So this is the actual vehicle of an 8-year-old little girl who the family has given us permission to share her story with you. She was restrained, although we're not sure of what type of belt. I suspect it was lap belt only, who was a left rear seat passenger in a 40-mile-per-hour head-on collision. Here are the pertinent positives in her primary and secondary survey. By the time she got to us, in red you'll see her C-spine was tender, mainly at the left lateral neck. She didn't have any step-offs, but did have continued tingling in her left upper extremity with sensation and motor intact. I'll mention her imaging findings to you here in a minute, but most impressively, she had significant abdominal distension. For plain films in the emergency department, we got a lateral C-spine that showed C2 to C3 subluxation. Her chest x-ray was normal, her pelvis film was negative, and ultimately we decided to do a CT of her C-spine because of concerns from the plain film and that she had continued tenderness to palpation and this neurosensory deficit in the left upper extremity. And then we also did a CT of her abdomen and pelvis due to the distension and pain. So here is her C-spine. You'll see right here this non-displaced fracture of the anterior arch of C1. But most significantly, she had this bilateral pedicle fracture of C2, and the right side extended into the transverse foramen, causing this anterior subluxation of C2 onto C3, as you see here. What can't be appreciated here is that due to that fracture, CT had rotated onto C3 with a jumped facet on the left. So we were definitely concerned about her C-spine, and she remained in the collar. For her abdomen, she had this impressive grade 4 splenic laceration with greater than 25% devascularization of her spleen. Here you see it in a different view, all this hypoperfused area here. She had a small grade 1 liver laceration, and in this view you see a decent amount of blood in her paracolic gutter. What can't be appreciated on any of these images is she also had a very small grade 1 left renal laceration. So she was taken from the ER and admitted to the ICU for close monitoring and serial exams. The plan was for her to go to the OR the next day with orthopedic surgery for halo fixation as an add-on case. Here is a course of her vital signs where you see that early on her heart rate was mildly tachycardic in the 130s, came down, hovered around the 120s after her original fluid resuscitation, but then overnight she persistently increased to the 150s. So my concern in looking at her vitals at 5 a.m. before seeing her was that she had some continued bleeding or oozing from her spleen and may not succeed non-operative management. And when you look at her blood pressure over that same time frame, this is time from admission, her blood pressure remained pretty stable, definitely above the 100s range, which we know kids have immense physiologic reserve. She could still be bleeding and just maintaining her blood pressure for now. But when you add in her hematocrit trend profile over that time, it kind of didn't fit. So she came in barely 4 hours post-admission with a crit of 31.5, very minimal difference, about 8 hours in, 14 hours in, we're back to where we started. So she doesn't really look like she's actively hemorrhaging from this picture. She also was making good urine throughout the night, although early morning started to fall off at about 0.7 mils per kilo per hour, despite multiple fluid boluses throughout the night. And while her belly remained tender, she really wasn't peritoneal. So we decided then that as she was this add-on case for the OR to get her halo placement with orthopedic surgery, that the head of our trauma program, Dr. Mooney, would go in and just do an exploratory lap to make sure we weren't missing any bowel injury. Now, the original abdominal CT didn't suggest it in any way, but we know that CT is notoriously bad at picking up abdominal and intestinal trauma, So she goes to the OR, and it happened to be a slow patient day for me. And never in my time at Boston Children's Hospital had I gone into the OR to observe, but this day I asked the orthopedic surgeon who was doing her case if I could, which he was lovely and fine with. So as I enter the OR, which is a scary place for me because I have never been an OR nurse and I'm always afraid I'm going to touch and contaminate something and get yelled at by the OR nurses, I went and hid in my corner next to a phone and next to the documenting nurse. And the documenting nurse was actually cross-covering for another nurse who had gone off to lunch, so this wasn't her normal OR team either. And as they start the induction to intubate this little gal, her saturations start to drop. And I first can just hear the tone dropping. And now I'm closely watching the monitor. And she went in at 100%, and as they're trying to intubate, she's dropping to the 90s, then the high 80s, then the low 80s, then the high 70s. And I'm kind of watching the team to see if anybody's going to react, anybody's going to respond. And although I feel like I'm a pretty seasoned nurse, this isn't my place and these aren't my people, and I was feeling very uncomfortable about speaking up. But finally, when her pulse ox hit the high 60s, I hollered out and said, "Do you see that her saturations are now in the 60s?" And the anesthesia team, who of course had been focused on getting the airway, looked up and realized it too and abandoned their efforts and were bagging her back up. So after pre-oxygenating her again, which she only really got back up to the 90s, mid to low 90s, they went to reattempt. And this time the same thing happened again, yet now I'm watching her heart rate start to drop. So she went in the case in the 150s range, And now she's in the 120s, 100, and precipitously drops to the high 40s. And again, nobody's doing anything or saying anything except for trying to intubate. And so I hollered out, we need to start CPR. Everybody looked up, noticed what was going on, and immediately started CPR. And I looked at the documenting nurse next to me and said, do we call codes in the OR? Like, I don't know, I'm not in the OR. We call codes on the floor. Is there a code team that responds here? So she immediately called the code, and all of a sudden the room is flooded with an enormous amount of staff, meaning anesthesiologists. And I called my colleague who was sitting in her office and said, please tell Dr. Mooney what's going on. I think she's probably arresting from her belly, not from her C-spine issues. And I knew Dr. Mooney was just down the hallway in the OR finishing up a hernia because after that he was coming in to do this little girl's exploratory lap. So in the minute or two as CPR was taking place, it felt much longer than that, it was absolute chaos. People yelling over each other, people demanding drugs, demanding equipment, and you really couldn't tell who was in charge or what was going on until Dr. Mooney walked in the room, stood on top of a chair, and screamed at the top of his lungs, who is in charge here? And the anesthesiologist who was attempting the airway looked up and said, I guess that's me. Because in the meantime, the orthopedic surgeon had taken over a vice grip hold on this little girl's C-spine. He didn't want resuscitation efforts to damage her C-spine or cord, and so he very appropriately was fixated on holding manual stabilization of her C-spine. So as soon as Dr. Mooney said that, the anesthesiologist said, I guess that's me. And he said, fine, don't touch the patient, come talk to me and tell this room what's going on. So the anesthesiologist gave a great rundown of the case scenario, her history of present illness, and what they were doing in the OR. And it was amazing to watch how, in that moment, everybody snapped to order. Dr. Mooney directed the other anesthesiologist at the head of the bed to continue airway, directed drug management, and then said, give me a large bore needle, stuck it in this girl's abdomen, where she had a large amount of hemoperitoneum and succus that was relieved, and immediately her heart rate came back. So she had a nice jejunal perforation and had been spilling GI contents into her abdomen and probably systemic inflammatory response and likely pressure on her vena cava from it that led to this collapse, cardiovascular collapse. But she was resuscitated and her abdomen was left open for 4 days with the wound back, but then closed. She extubated on day 5, went to the floor on day 7, and home on day 16. When she came back to us in follow-up clinic, she was seen multiple times, her mother encouraged her to tell me about her dream while she was in the OR, and she had not been told that she had arrested while she was in the OR. Obviously the family was, but the mom didn't want that shared with her. And she became shy and kind of withdrawn every time the mom asked her to tell me her dream. But finally, in one of her final visits, she said, well, you know, when they took me to the operating room to fix my neck, I had this weird dream where there was this crazy man up on a chair screaming and yelling at everybody, but he had this beautiful rainbow over him. So I have no doubt that was Dr. Mooney, and this was our little girl's rainbow dream, as she calls it. So I tell you this case scenario because it points out exact phenomenal principles of crisis resource management training. CRM training, which Boston Children's Hospital Simulator Program, which has been there for 15 years now, does a phenomenal job of teaching throughout our institution, throughout our community, and worldwide. So if you're interested at all at having them come teach your institution, please contact me through Brian at the end of this, and I'm happy to put you in touch with them. But it provides an exemplary healthcare and CRM training does and projects confidence to our patients and families that, as you just saw, really saves lives. And it's having a plan in place and a process that helps address significant stress or crisis. And the goal is really to create a common language throughout the institution and teamwork so that we all have the same approach to crisis and stress. It also helps us evaluate how teams work together in crisis because the literature would suggest that 70 to 80% of medical errors are due to human factors. So it helps us address all of these things. Here's a picture of the Boston Marathon bombings, which definitely was a crisis situation. I think it's important to define what crisis dynamics are, and crisis is defined as a non-routine situation with a high uncertainty of risk. It brings on stress, your attention narrows, you become fixated on things, it can make you feel and act very disorganized, and you have a loss of situational awareness. Now, a lot of these reactions are the result of involuntary physiologic changes. It's the fight or flight response with catecholamines flying throughout. But we can counter this reaction with education, recognition, and training, which is why we do CRM. So here are the 5 tenets of CRM, or 5 CRM principles. We'll go through them in more detail. First is global assessment. So there has to be someone who maintains this 50,000-foot view. We just saw why having the big picture is so important. There needs to be one person who's not locked into tasks, who's not touching the patient, who gets to sit back and just take it all in and see it all. And although the event manager, as we call it, is usually a senior or seasoned physician, there are things that we can all do to help ensure that we maintain a big picture. And one of those things is cross-monitoring each other. If you feel like someone doesn't have the big picture, you can ask if there's a working diagnosis here that we're using, or you can ask someone to re-verbalize what we think is going on here, or reviewing frequently. Can we have a rundown of the case up to this point? And we pause and do that often in our resuscitations in Boston for a multitude of reasons, but part of it is this, so that everybody in the room has the same information at the same time. And it helps all of us avoid fixation. Another tenet of CRM is resources. Have you ever been in a resuscitation or been in a crisis situation where you can't find a piece of equipment when you really needed it? That not only drives me crazy, it also has negative effects and impacts on our patients. So anticipating what you need, particularly running down the line of a worst-case scenario before the worst-case scenario happens or before your patient arrives, can really, really be helpful in anticipating the resources you might need. So we're talking about local resources like equipment, but also global resources, like is the OR aware, or is the CT scanner open, or do we have an ICU bed available? A lot of those things can be put into place before or immediately upon a patient's arrival to help make sure all of your resources are available. Personnel support is also key to CRM. Do you have the right people in the right place at the right time? Particularly, do you have the right people in the room? You may know that you have a significant head injury coming in, but someone forgot to notify neurosurgery and forgot to make sure the OR was available. And then what do you do if you have too many people in the room? That too can have negative impacts. We have all seen that. And please make sure that you orient late arrivals as they come in to your resuscitations. Many times you may have a surgeon who has to break out of the OR to come down and respond, yet you're already 5-10 minutes into caring for your patient. You need to stop, review, and make sure that they're oriented to everything that has happened up to this point. So communication. We hear about this all the time, but there are a couple things that are key to communication in CRM principles and in life. The tone, particularly for the event manager, is so, so important, because how you say something can be just as important as what you say, and you need to make it safe to speak up. Research shows that, particularly in healthcare, often lower status, in quotes, individuals are often reluctant to speak up. So the clinical assistant may be sitting back and have a great view of what's going on, that the level 1 isn't working properly, yet the nurse who set up the level 1 is now engaged in a new task, yet the clinical assistant may be nervous to speak up. So we need to make it safe for people to feel comfortable to do that. And one of the ways we like to train our staff is by asking them to say before the resuscitation starts, hey, I may miss something here. I know that I can't see everything or know everything that's going on in the room, so I'm asking you now, please, to feel free to bring it to my attention if you have a concern. And it really has changed the way people talk and communicate and relate in our trauma resuscitations. We all know about closed-loop communication, read-back feedback, particularly for orders and drugs, but also making sure to ask for help. Let's say you're assigned to a task that you really don't feel confident about or know how to do well. It's okay to say, you know, I haven't used the bear hugger in 6 months since our last education day. Could somebody please help me set this up? Because ultimately that's helping your patient. So role clarity and leadership are also very important within resuscitations. If we have noticed before a patient comes in, we try and all meet and huddle together before the patient's arrival, introduce ourselves to each other, particularly in large academic centers. You can have rotating residents and fellows and 100 ED attendings and over 20 surgical attendings like we do. Although the ED team usually knows each other, people coming from outside the ED often don't know each other's first names. So we like to orient each other ahead of time about, here's my name, here's my position, here's my role in the resuscitation. But we also have sticker labels that we wear on our yellow gowns. So if I look up and have a question and I don't know the ED attending's name, I can just say, hey, ED attending, while I'm looking him in the eye or her in the eye. So to make sure that we have direct communication. So this picture cracks me up. As you see, these lovely divers are clearly unaware and don't have situational awareness of what's going on behind them. But this event manager role is really pivotal to CRM. And the identity of that person needs to be clear to every single person in the room. That person's responsible for making sure that all the roles are clearly assigned. They're responsible for maintaining a respectful tone at all times. And their job is really to maintain the global view, which means they can't dive into specific tasks unless they hand the event manager role off to someone else. And I know some institutions that actually have a hat, an event manager hat. And let's say it happens to be the attending surgeon that day, but the kid needs a chest tube and the fellow needs help with that. The surgical attending will take off the event manager hat, hand it to the ED attending who now wears it, and now the surgical attending is free to dive into a task because he no longer is responsible for this situational awareness. But you can really see how you can lose focus and become fixated and lose the situational awareness when you take on tasks. So role clarity, we've talked a little bit about here, just a few of the roles in our institution that are responsible for crisis situations or resuscitations. But just make sure that everybody's clear not only on what other people's roles are in the room, but that we don't put staff in those situations unless they're clear on their own role and comfortable with it as well. So communication, you see strategies for positive communication there. We'll just spend a second on some of the barriers, though, to good communication. And a big one is when people give hints. You don't want to say, would you like another fluid bolus? It would be much more effective and direct to say to the event manager, our heart rate is progressively tachycardic. We're now in the 160s, and our blood pressure is starting to soften. Our systolics are in the 90s. Would you like another fluid bolus? Much more direct, gives the information behind why you're suggesting what you're suggesting, and doesn't give hints and leave things up to interpretation. The other big barrier to communication is this whole succumbing to the pecking order and not sharing your concerns or questions, like me in the OR. I was really nervous, really hesitant to speak up and to say anything about our little girl's sats dropping and then heart rate dropping because it's not my people, it's not my place. They don't know me, they don't know what I do, they don't know who I am, I don't know them. So it can feel really uncomfortable. But if you have a concern about something being addressed or not addressed, bringing it up and exploring it will either help you understand the bigger picture or it'll bring light to an unrecognized omission. So it's kind of a win-win. So we practice all these CRM principles through simulation at Boston Children's. Once a month, we have a native team, as we call it. That means the real team players that would show up for a trauma resuscitation in the ED, as well as surgical fellows and surgical attendings that attend these simulations. And we run real patient scenarios of kids that we've taken care of in the past. And we practice the CRM principles that are discussed during the didactic phase of training during simulation. And then most importantly, we go back after the simulation and do debriefing or reflecting on action. And you see here the different stages of debriefing. The first is to sit down and just kind of say to everybody, okay, wow, how did that feel to you? How did that simulation feel? And it's lovely when most people sit down and say, oh my God, that was so stressful. That was just like a real resuscitation, and I'm like sweating through my shirt. That tells you it's been a real good, what we call high fidelity simulation, and really brings out real life resuscitation issues. But it's important to kind of let people shake off the emotions first so that we can get to the real work of debriefing. But as healthcare people, we also really want to know kind of the facts of the case. Because often we don't finish the simulation scenario, so they don't know a diagnosis, they don't know if the kid lived or died, and as you all know, we want to know that. So you have to go through and discuss the real case and get the facts out of the way so that we can move on to the analyzing phase of debriefing. So during the analyzing phase, we say, what do you think went well in this case, and where as a team did we excel? So look at the positives, and then go look at the cons and say, okay, so what didn't go so well? What didn't go as expected? And where are our opportunities for improvement? And what amazes me is that almost every time the same issues arise again and again and again. And the issues that arise are the 5 core CRM principles that we just mentioned: global assessment, resource issues, personnel support issues, communication issues, or role clarity and leadership issues. It's rarely, if ever, a knowledge deficit issue on how to take care of the patient. It's related to all of these other system processes that are beautifully addressed through CRM training and simulation. So just to revisit, how do patients and families define excellence? Well, patients and families see it, feel it, know it, and benefit from it when these CRM principles are put into practice. They appreciate the calm, controlled environment where there's clear direction, and they know that that results in superb care. So remember, practicing and becoming more proficient at CRM principles saves lives, and it's important to our families and defines excellence in their eyes. So to our second scenario, I just think this speaks beautifully to what we'll discuss in this art of holding space. But sometimes we need someone to simply be there, not to fix anything or to do anything in particular, but just to let us feel that we are cared for and supported. So the second main theme that arose in relation to excellence in patients and families' eyes are what you see listed here: being attentive, being an active listener, feeling our kindness, feeling that they were really heard and respected, and that we shared decision-making and power with them. Some of the specific comments were, we loved being included in rounds every morning. Our son really felt listened to when he was asked what he thought was going on with his body. Everyone was just so kind. You really cared about what we had to say. You waited on rounds for us so we could participate as parents. We felt like our opinion really mattered, and you trusted that we knew what was best for our child. So those are just a few of the comments. So here is my most memorable day at work ever, and I can't give you all of the details because it ended up being a legal case, but I can share enough with you so that you appreciate how this reflects what we just talked about. So this story, I hope, demonstrates to you how attentiveness, active listening, being heard, sharing power and respect can save patients' lives and support excellence in care. It's about a school-aged little girl who was evaluated after falling down a set of stairs early in the morning and about an hour prior to arriving to us. She was found at the bottom of 14 stairs, initially unresponsive, but aroused with shaking, with full recall of the events. She originally complained only of right shoulder pain, but then a little bit later of significant abdominal pain. And her mother felt like she was not acting right. So the social history reflects that she lives with an adoptive mother, her biologic sister, and an adoptive brother, and that she had been removed from her biologic family at age 2 due to multiple forms of abuse. So on physical exam, you can see here the pertinent positives. She was tachycardic. She had a minor abrasion over her right eyebrow, but most impressively, she had a firm abdomen with diffuse tenderness and guarding. Her labs reflected a low hematocrit at 32.3 and elevated abdominal chemistries. Her image findings reflected an impressive grade 4 liver laceration with extensive hemoperitoneum. You see the blood tracking around here. In her hospital course, she was admitted to the medical surgical ICU unit on our solid organ injury clinical pathway guideline. We were hoping for non-operative management as she was relatively hemodynamically stable. You see her hematocrit trend here. And she initially complained of this right shoulder pain that improved with pain management. So our team emails sign out to all members of the surgical team because it's such a big group. And so I happened to be sitting at an STN conference years ago reading the email sign out about this little girl's admission. And I just remember thinking that this doesn't seem right. Like the mechanism of injury just doesn't fit the resulting injury we see here. She didn't fall from the top of the stairs down a full story directly onto a banister. She reportedly tumbled down the stairs, and so I just didn't feel right about it. Consulted with one of my colleagues who felt the same, and so from halfway across the country, we emailed the team back and said, could you look into this further? It doesn't feel right. You might want to get child protection team involved. So they did. They interviewed the mother. Everything reportedly checked out, and the child protection team signed off. And it still just made me very uncomfortable. So I spoke with Dr. Mooney, and he said, she's going to be in the hospital for at least 5 days, given her grade of injury. We'll see her on Monday when you're back, and we'll visit her in the morning. So she was transferred to the floor on hospital day 2, and we go in Monday morning and interact with her for the first time and do history and exam. And we sat on her bed and said, we know you've told your story before, but we haven't met you yet. Would you mind sharing it again? And she very quietly, and would not make eye contact whatsoever, kind of retold the same story that had been told previously, just that she fell down the stairs. When we asked her a few more details, she kind of wouldn't respond. She was pretty quiet. So ultimately, Dr. Mooney had to take off to go to the operating room, and I thought, I'm going to hang behind. I wonder if she just won't engage and won't talk with the male, maybe because of her history, I don't know. So I sat and stayed with her and just listened to her and asked her about herself, asked her if I could turn off the TV so that we could engage a little bit more. Asked her what she liked in life, what her favorite class was. And she slowly started coming out of her shell, but she told me a couple things that made me even more concerned than I was previously. So ultimately, after about 30 minutes, I know that I had to move on with my day as well. And I said to her, honey, I need to head out, but I'll be back and see you later. Would you mind sharing with me one more time how your tummy got hurt? And she fell apart in tears and disclosed that someone in the home had choked her to near unconsciousness and stomped on her belly, and that there was a pattern of abuse in the house to she and her sister. And as she was crying, and now I'm crying, she says, do you know what, Miss Heidi? Every time I see a penny, I pick it up. And I said, you do? Why do you do that? She said, well, you know, you get to make wishes off of pennies. I said, oh, that's right, you do. What's your wish? She said, I just wish that I could find a family that would love me. So, of course, now we're both sobbing. Went home and made her this penny necklace that she still wears today. Ultimately, came to find out that she had a couple of rib fractures as well. The story of abuse was corroborated and the perpetrator was arrested, and she and her sister are now, last I knew, in a happy, happy home. So thank God our patient did well. But I feel like she felt secure enough to share her story with me and to tell me of her penny wishes through this art of holding space, that she felt safe, she felt unjudged, she felt listened to, and she felt respected so that she could share her deepest, darkest secrets. So I love this comment from Heather Plett, who says that often the hardest thing about holding space is that it can feel like you're doing nothing. And that silence that you hear, did it make you feel uncomfortable? Most of us, particularly nurses, don't like silence. It makes us very uncomfortable because we feel that we need to do things. We feel like we need to fix things. We feel like we need to help people. But if by being silent and by being fully present, if it's done right, it's a huge gift to our patients and families. We all want to do something, particularly when a patient or family member is hurting or confused or overwhelmed. And it's really hard not to step in and try and fix the situation or offer resources or give advice in some way. But just as often, what people really need is just our presence more than they need our actions or advice. And here's a quote from the late Alice Miller, who is a psychologist in England who wrote on child abuse. She's a psychologist, from Switzerland, a psychologist and a psychoanalyst, that we are all called to be enlightened witnesses, people who through kindness, tenderness, and focused attentive love return people to their authentic selves. And the reason I love this quote is it helps remind me that we are not meeting our patients and families who are themselves. They are not their authentic selves. They are in crisis. They are out of their normal environment. They feel more vulnerable, scared, and exposed and out of control likely than they ever have in their lives. And this art of holding space can hopefully help return them a little bit to their authentic selves. So we'll talk a little bit more here about holding space and how we can do it, and understand that, of course, there are barriers to doing it. We often just don't have time. We've got so many things on our checklist. We've got so many other demands that we can't find 15 minutes of uninterrupted time. The acuity of our patients sometimes don't allow us to do this. Obviously, their physical and physiologic needs come first. There are so many competing demands on our day. Do I take off my pager? Do I take off my phone and hand it to a colleague so I can go in a room with the patient and family for 15 minutes? Or do I take my lunch? Or do I get a lunch break? Or do I help my colleague turn their patient? We have tons of demands. Guilt on behalf of our patients and families, particularly in our trauma world, also can interfere with families wanting to share, with being able to open up. They have such overwhelming guilt inside about what's happened that can be tough. Acute stress disorder, we'll talk a little bit more in a moment, also can keep patients and families from being able to participate in holding space. And this power imbalance that's inherent in a patient-provider relationship we will also address. So I just want you to try and change your vernacular in the future. Not that we're helping our patients, because helping someone creates this power differential, but serving someone is a mutual act between individuals. So what can we do to level this playing field so that patients and families don't feel this power imbalance? This is kind of a wordy slide, and we won't address it all in the effort of time, but we can be honest that, we get that we're not all the same, and so don't pretend that we're all the same. We, as clinical providers, often have great clinical knowledge that our patients and families don't have, yet our families have intimate knowledge and understanding of the patients that we serve so that we both can bring something phenomenal to the table. Paying attention to physical space is so important. I rarely, hope never, stand over a patient anymore. I sit down on their bed, I sit next to them in a chair, just so that they know that it's an equal free flow of information back and forth relationship. We want to create safety for difficult conversations, things like care conferences where you have health providers lined up on one side of the table, families on the other side, still supports this power imbalance that we don't want. And don't be afraid to say, I don't know. I think makes patients and families feel very safe and feel that we're honest, but follow that up by saying, but I will find out for you. So here are some tips to holding space. You want to make sure that you're giving your complete and undivided attention to the situation or person at the time. I love this comment of lose control down below. What that means is that you don't go into the conversation with an intended outcome. You go in and just be fully present and there to listen to your patient or your family, which is why it can feel a heck of a lot like you're doing nothing, but it's an art, and it really is the art of nursing. We're the ones who get to know the patients and families so well. We're the ones who get to be with them minute in and minute out. I've had several people suggest that this is social work. And I would say if you have a social worker who can be in the room minute in and minute out, I'm sure they would be phenomenal at this. But we're the ones that really make the close connections and the ones that are there and the ones that patients and families are most likely to succeed in this process with. So I love this statement. Sitting quietly, mindful of the living moment, not doing, not seeking after outcomes, yet aware of a profound opportunity for transformation. Not interfering, not hoping, not fearing. Surrender yourself to compassionate sharing. Holding the experience of sacred emptiness. Let go, step out of spirit's way. The moment is pregnant with benign possibility. So giving people our presence can feel a whole lot harder than giving them our advice. It can make us feel vulnerable and useless and unproductive, yet when families talked about what their greatest support was during difficult times, it was often the people who knew how to just show up and be with them that were the most memorable. So in summary, these are what our patients and families reflected as what they defined as excellence in care, either for themselves or for their child. A calm, controlled environment with clear direction that results in superb care, which I believe we achieved through strongly committing to learning CRM principles in our institution. And this attentiveness, active listening, being heard, and sharing power and respect, which can be achieved through learning more about holding space. So people will forget what you said, they'll forget what you did, but they will never forget how you made them feel. And that's essentially what our patients and parents said, that we don't remember the specifics, we just remember there was a sense of calm, and we remember being well cared for, and that was immensely reassuring. So thank you for your attention today. It has been my honor to be able to speak with you. Does anybody have any questions?
Thank you very much, Heidi. We currently don't have any questions in the question queue, so if you are attending and you do have questions, please send them to info@traumanurses.org, and we will forward them along to Heidi. And also, as a reminder, you will be receiving an email in about 1 hour with a link to the evaluation, so complete that and you'll receive your CE certificate in about 7 to 14 days. Thank you again for attending, and have a great day.